aspect of the acromion and the humeral head. And that's where if the bursa was inflamed, you would feel swelling or gushiness. Think about a water balloon, okay? It would feel like it was fluid filled and you could push it in and it would spring back at you. If you don't have an inflamed bursa, it's going to be unremarkable. You're not going to reproduce symptoms, you're not going to feel any swelling in that space. Now that bursa can be called either subacromial or subdeltoid. You will hear those used interchangeably. They're talking about the same bursa. Some people anatomically will have more than one bursa in that space, so they might have two separate bursae in that area, but clinically we can't tell the difference between one and the other. So when we talk about the subacromial subdeltoid bursa, again, you're just coming off the lateral aspect of the acromion and just sliding down into that space. That space is also going to be really important to palpate for people who've had a stroke, where their arms are paralyzed, so not when they have increased tone, but rather when they're really flaccid, because what will happen is the humeral head will actually fall out of the glenoid space, and you'll be able to feel that because there will be a huge gap right there. Okay, so that's another reason why you might want to palpate this space. Okay, the deltoid tuberosity, you're just going to follow the muscle mass of the deltoid to where it attaches on the humerus, and so you're just following the contour of the deltoid down. What is Wolff's law?
Tissue will form based upon the strain that's placed on it.
Yes. So the deltoid tuberosity is the deltoid has pulled on the bone, causing there to be a little bit of a bump where the muscle attaches to the humerus. The deltoid tuberosity is an important thing to palpate because it is a common referral spot for people who have glenohumeral pathology. So they may tell you, oh, my shoulder really hurts, and they're actually rubbing right over their deltoid tuberosity. What that means is they actually have a structural problem inside their glenohumeral joint. So they could have had a dislocation, subluxation, labral tear, but that referral pain is going to be at the deltoid tuberosity. Okay? So the structures that we had left on our sheet were the deltoid tuberosity, the subacromial sub Deltoid bursa, the supraspinatus attachment, I believe is the last one on our, oh no, we have to do the anterior limb of the glenoid. That one, so I just struggle because we're doing it so early. That and trying to find the greater and lesser tubercle are just tough to find. It's important to find, and you will all find it, I'm confident. For the supraspinatus attachment, remember that there's a common tendon that's coming across and it's attaching onto the humerus. The only way we can actually palpate the attachment of the supraspinatus is by extending the humerus and then coming directly off of the anterior aspect of the acromion. There's not going to be anything remarkable that you're going to be able to palpate. Now you do want to make sure you're off the acromion and you're actually on the humerus. Okay? So if you're palpating there, you're not going to feel that there's a tear. There probably won't be a tear in the supraspinatus right at its attachment point, but rather you're going to have reproduction of symptoms so that if they have a cuff tear, that may be tender upon palpation. But you are not going to, so for that one you really are looking for reproduction of symptoms and really nothing else. You're not palpating for structural integrity, for example, of the supraspinatus at that point. So the structures that we're talking about now, the subacromial or subdeltoid bursa, you're coming off laterally off of the acromion. The deltoid tuberosity, you're going to follow the arm down and palpate where the deltoid attaches on the humerus. For the supraspinatus attachment, you're going to extend the humerus and you're going to come directly anterior off of the acromion. So inferior to the acromion off the anterior aspect. Okay? So let's go ahead and palpate those. It seems like you're all doing fine just flipping and when you're done, so instead of me formally telling you to switch, just do what you're doing and I'll acknowledge that and stop trying to get you to do something else. Okay.